So, Ron, thank you very much for introducing me. Yes, Sir Winston Churchill said the famous story just before his death. He said, quote, "My life is too short to understand Germany." So also I would say my life is too short to understand this tough glomerular disease called as Podocyte Infolding glomerulopathy. I think as yet it's a very severe and tough glomerular disease whose pathogenesis total not yet known. So first, what we should do is correct subtypes we would propose. With this the standpoint for future research, I would say. So. Thank you.
Yeah, I can bring it up that we have time.
Yeah. So for the linear pathologist, this figure is astonishing. So because the microtubules spreading in the GBM, thickened GBM, together with extensive food process investment of podocytes. So why has this peculiar regions not yet been as far approved? It may depend on the very rare regions. The present study identified 93 cases over 34 years. So since approximately 20,000 kidney biopsies are performed annually in Japan, the incidence of the case with this region is estimated to be about 0.10% in Japan. So I go back to the first research working group of the Japanese Society of Nephrology, 2008, over 25% patients from 17 institutions. So I proposed the new disease entity called as podocytic infolding glomerulopathy in this journal, Clinical Experimental Nephrology. That is the official journal of Japanese Society of Nephrology. So I show you some examples. In light microscopy, this figure looks like focal segmental glomerulonephritis. But you can see the crater formations on the GBM by Jones stain, which is similar to the primary or membranous glomerulonephritis. However, the immunofluorescence showed faint positive only for IgG as a granular pattern. Faint positive. And in electron microscopy, you can see the spreading of microsphere in the GBM. So extensive globally, we can find these microsphere in the GBM, together with extensive food process investment. So each microsphere shows three lamellar structure, which is known as unit membrane. The unit membrane is, of course, also seen in the podocytes. So maybe this is corresponds to the crater formation in Jones stain. second case shows the microlamellar structure situated just in the sub-epithelial space. And fourth case shows podocytic infolding deep in the GBM, where the microsphere can derive from these cytoplasma of infolded podocytes. And fourth case show again in John stain, you can see the crater formations. And this shows the positive staining for IgG, C3, and C1q, mainly in the mesangial area. And C5b to 9 were positive along the whole glomerular basement membrane. So in electron microscopy, the microsphere can be seen, and partially is the continuity to the podocytes. But Dr. Fujigaki wants to have evidence that the continuity between podocytes and spreaded microsphere using 3D reconstructions, composite image created by taking 90 images of transmission electron microscopy sections by varying angle. So it's a successful result is the podocyte is connected with the spreaded microspheres. And here also the podocytes connected with the microsphere in the GBM. So, and also interesting that this microsphere is positive for biometin, which is a marker of podocytes. And also a membrane attack complex, also positive. That means the microsphere complements active. So clinical finding of 25 patients, the age is the middle age, and very, very rare in children, and female predominant, and all cases show the proteinuria, among which about 25% developed nephrosis syndrome, and few cases hematuria and hypertension was seen. And as a combined disease, collagen disease in 17 patients, including lupus nephritis, Sjögren's syndrome, and mixed connective tissue disease. And as a non-collagen disease in 5 patients, including vesicular reflux, bacillus disease, chronic thyroiditis, hepatitis B, virus infection, so on and so. And no concomitant disease were found in 3 patients. So immunofluorescence findings among 25 patients, 8 patients, including non-collagen disease, immunoglobulin negative. And the resting 17 cases show IgG only is the most frequent, and IgG together with the heavy chain and complements were also seen. But the frequent is not so, it's so predominant. So as a prognosis, remission of proteinuria in 15 out of 23 patients within 12 months. And proteinuria became in remission without steroid therapy in 7 patients. However, proteinuria remained higher than 1 gram per day in 5 patients. As renal functions normal in 21 cases, and however, in 4 cases become renal failure, who are all hypertensive. As a therapy, so at that time, 2008, so the therapy is different from now present therapy. So prednisolone administered in 18 patients, including pulse therapy in 3 patients. Only MMF and cyclosporine A are administered in 3 patients. So proposal of this disease entities term is podocytic infolding glomerulopathy, abbreviated PIG, and crater formations in John stain, which is similar to membranous glomerulonephritis stage 3, and EM, microsphere or microtubular structures associated with podocytic infolding in the GBM. And microsphere were at the end of the infolding plasmacytic process of the podocyte, measuring 50 to 150 nanometer with trilamellar limiting membrane structure, which is known as unit membrane. In IF, immunoglobulin faint positive or negative. So at that time, we proposed 3 subtypes, including type A with only primary infolding, and type B with primary infolding plus microstructure in the GBM, and type C is only microstructure in the GBM. So this subtype has been acknowledged internationally. However, definition of podocyte infolding was obscure, and these subtypes did not distinguish a type with microsphere from the type with microtubers. So the diagnostic morphological criteria remains insufficiently defined, leading to the diagnosis ambiguity, whereas PIG has been globally recognized with increasing case reports and cohort studies over the past 18 years. So therefore, we investigated the morphological definition of PIG by first clarifying its subtypes on the basis of transmission electron microscopy. So come to the Act 2, the second research working group of Japanese Society of Nephrology 2025. So the method and materials, retrospective observation, nationwide multicenter studies. So as a patient, a PIG diagnosis or suspected case were collected with transmission electron micrograph and clinical data from 16 institutions between 1991 and 2025 in Japan. So electron microscopic assessment referring podocyte infolding, microsphere, microtubules, cluster formations, GBM thickening, electron dense deposit, and food process effacement. These items were statistically analyzed. So first, the definition of PIG based on transmission electron microscopy, podocyte infolding extending to at least half of the GBM thickness observed at 2 or more distinct sites within the single glomerular capillary loop, and or presence of microsphere or microtubules within the GBM. So new subtype established as below, collected 103 cases and excluded 10 cases, and listing 93 cases fulfill the newly established definitions. So targeted the presence of microstructure in the GBM when no, included in type A, when yes, targeted presence of microtubular structures, when yes, included in type C, when no, these cases all shows the microsphere only, but microsphere shows dense cluster formation when yes, included in type B, when no, included in type B. So what is the morphology of type A? Here is extensive food process effacement and infolded deeply in the GBM. And this is the other case is infolding of the podocyte with electron-dense deposits. But the amount of these electron-dense deposit is not so massive as seen in the primary membranous nephropathy. And type B here is microspheres spread in the GBM, in thickened GBM, and among which some spheres show a targetoid structure see in inlet. So we use again want to analyze the spatial relationship between podocytes and each microspheres in this disease. This was type B cases. So here is the podocyte and imported into the GBM, and microsphere can be seen, and some of which stick to the surface of the podocyte infolding, but most of the sphere is touched off from the podocyte and situated deep in the GBM. And you can see that every microsphere cannot transform to the microtubular structures. And some of the sphere makes a loose cluster, but this cluster cannot strictly surround the, not surround around the infolded podocytes. So type C, as I've shown you, is the microtubular structures spread in the GBM. And this case shows no cluster and very few podocyte infolding into the GBM. So this type is clearly differentiated from the type B. So in higher magnifications, you can see these microtubular structures together with microspheres. But these spheres can be a cross-section of microtubules. And we can see this surface of microtubular structures. I don't think that is the trilamellar structures known as unit membrane. To my opinion, I cannot see in these microtubules. So type D is cluster, dense cluster formation of microspheres situated in the epimembranous area. The other case, you can see this distribution is like membranous glomerulonephritis, but each deposit has a dense cluster in it. So this is the type D. And in electron immune complex, we can see not only IgG, but also IgA and IgC3 strongly positive on the glomerular basement membrane. That means immune complex mediated disease. The type D is immune complex mediated disease. So this is very rare case. Also in primary membranous glomerulonephritis, here is the deposit just beneath the enfolded podocytes, and some of the deposit contains dense cluster of microsphere, but this case is very rare. So new subtypes established shown in this slide. So what is the profile of each four subtypes regarding the following items: podocyte infolding, microsphere, microtubule, cluster formation, dense cluster formation, electron dense deposit, food process replacement, and GBM thickness. So this table is summarize whole 93 cases referring to the electron microscopic findings items. So black is no, white is yes. So seeing these tables, we classified as subtypes from type A, B, C, D. So I summarize by these tables here. So the profile of subtypes can be seen in these tables. So type A, 100% podocyte infolding, of course, is not associated with the micro structure in the GBM. And age is almost 70 years old, and male predominant, and concomitant SLE is 0%. And type B, type C is clinically similar because this average age is around 50. This is higher ages in comparison with the normal lupus nephritis, the age of normal lupus nephritis. This type B, type C is almost 15 years older than normal SLE patients. And sex is the female dominant, and both is concomitant SLE. And type D, 80% podocyte infolding, and average age is 65 years old, and male predominant, and no concomitant SLE. So here is for the podocyte infolding, A and B between 80 and 100 here, and B is between 40 and 60, and C is under 20. So it's clearly a difference for the frequency of podocyte infolding. Electron dense deposit is almost similar between 20 and 40. And as for age and sex, type A and type B is between age is between 60 and 80, and male predominant, whereas B and C is between 40 and 60 years, and female predominant, and concomitant SLE 0% in A and D, and B, C is almost between 60 and 80%. So B, C, D are different. So we summarize with this scheme over the result of subtypes. Here is type A infolded into the GBM. Some case is electron dense deposit here, and type D is usually without the electron dense deposit, then only dense cluster of microspheres. Some of we can see inside of the electron dense deposit. But since these subtypes show immunoglobulin derived mediated glomerulonephritis, so maybe it's a subtype of membranous nephropathies. It's different from a PIG, I would say. And type B and C, of course, B is the microsphere. C is microtubular structures. And type B is found, some cases found in the electron dense deposit. But in type C, no, it's independent from the electron dense deposit. and both are related to SLE. But interesting, even both type belong to the SLE. But why is so different type can be seen in same SLE is as yet not known. So result, 93 cases fulfill the diagnosis criteria of PIG. And based on 10 findings, the number of type A is 21, type B 34, type C 38, and type D 10. So to our research, these distributions. And type B and C are observed in middle-aged female patients and showed high prevalence of SLE. And type A and D were more prevalent in older male patients and were not associated with SLE. So almost half of the case lacked electron-dense deposit, indicated that microstructures may occur independently of the immune complex depositions. And type D shares a feature with membranous glomerulonephritis with microspheres reported in previous studies, raising the possibility that this subtype represents a secondary form of membranous glomerulonephritis rather than a true PIG entity. So, as a topic, cases in which progression of lesion was confirmed by follow-up biopsy. So, little time, a few time left. So, only we will present the morphological change, not explain over the clinical data. So 30 years old female, first biopsy was done in 30 years, and 5 years later, the second biopsy. So here is in John Stein, the figure is membranous glomerulonephritis stage 3. And as yet, not yet, the glomerulus don't sclerotic, become sclerotic, and normal tuberous and normal interstitium. So here is the type B, can be seen microsphere in the second GBM. So in 5 years later, the glomerulus, the basement membrane, become thickened, and some of the glomerulus become sclerotic, together with atrophy, tubular atrophy, and interstitial fibrosis. And also in electron microscopy, the thickening of GBM containing more microspheres. So, however, immune deposit negative. And here is second biopsy here. After this second biopsy, the therapy began, and proteinuria decreased. And in these 6 years, the proteinuria remained between 4 and 8 gram per gram creatinine. However, serum creatinine increased until between 5 and 6 gram per deciliter. So the second case is 40 years old female with lupus nephritis. And after first biopsy, once proteinuria decreased, but 2 years later, proteinuria gradually increased. So here again is the, by John Stein, looks like membranous glomerulonephritis stage 3, and looking almost normal in glomerulus and tubular and interstitium. And here is the microsphere found in the subepithelial space. Very few. However, in these 2 years, the glomerulus become sclerotic, and together with the atrophy, tubular atrophy, and interstitial fibrosis. And here, in these 2 years, the microsphere become more and more with second GBM. So first biopsy, second biopsy, the immunoglobulin is faint positive. So the second topic is the diagnosis, differential diagnosis. Of course, here is membranous glomerulonephritis stage 2 and 3. So usually, primary infolding can be seen in membranous glomerulonephritis as seen. However, massive electron dense deposit. So I think it's easy differentiate PIG from membranous glomerulonephritis. But last night, the discussion with Dr. Cooperman and Dr. Chris, I have changed a little my idea over this disease. So this dense deposit through a relatively long time course, deposit will decrease and leaving microsphere behind. This possibility cannot be excluded. So the second differential diagnosis, Backwater has reported 55 cases in which extraspherical microparticles are seen. But to my opinion, this sphere is non-specific, finding often in the area where the podocytes come into contact with one another. This is not so no meaning. It's non-specific findings, I would say. And differential diagnosis 3, Kovalevska reported 14 cases with membranous glomerulonephritis spherical deposit in the GBM, forming a cluster of spherical structure. And also a targetoid appearance together. So this paper, 40 patients stained with anti-nuclear pore antibody and anti-neural and peptide antibody stain, and both are all negative. The reason why Dale and White reported that microparticles in the GBM observed in the membranous glomerulonephritis were nuclear pore complex, which were ubiquitous substances found within the nuclear envelope of eukaryote. So here is the membranous microparticle, and some of which show the targetoid structure. And this welcome party in this meeting, Dr. Brille suggested that this targetoid can be actin filament, so can be accepted his suggestions, but not yet proven. So Dibek and Ronco has presented the antenatal membranous glomerulonephritis with dense microsphere induced by antineural and peptide antibodies towards the new concept in the pathogenesis of glomerular disease. So Dibek published antineural membranous glomerulonephritis due to antineural and peptide IgG antibodies seen here. So that's the reason why also stained, these cases were stained by antineural and antibody, but all negative. So pathogenesis of prostate infolding glomerulopathy, it's totally not known, So only we say morphological findings microsphellae can be derived from budding from the cell membrane of podocyte Infolding tips, partially by breaking off from the disintegrated podocyte cell process and drifting into the GBM. However, the pathogenesis microtubules without podocyte Infolding is not yet known. So bimetalene was positive in intra-GBM microstructures, and attack complex was positive along the microstructures. And IFF2 mutations known to cause FSGS may link to the podocyte injury in this disease. And decreased ACNTN4 and tubulin beta-4 chain, which is acting cross-linking cytoskeletal protein for maintaining podocyte structure. So these molecules decrease, but it's not directly data over the pathogenesis of this microsphellae or microtubules. So conclusion, we defined a morphological framework by defining explicit term-based criteria, proposing 4 subtypes, enabling more structured interpretations of structured finding. These findings improve diagnosis accuracy and demonstrate the heterogeneity of PIG. And type D considered a subtype of membranous nephropathy, and I believe it is appropriate not to include in the diagnosis PIG, but this idea gradually I changed. So it's, it's not true, maybe. Future research will likely to be conducted using these subtypes as a reference point. So problems remain to be solved. Why do microstructure in GBM show immunoglobulin to be faint or positive or negative? Why do the distribution of microstructures in the GBM show be diffuse or cluster? Are these morphological changes specific for a new disease entity, or whether they reflect a cellular response of the podocyte injury? So future molecular and immunopathological studies are warranted to further clarify subtype-specific mechanism. So literature reviews, so for each subtypes is published already internationally. For type A, 5 articles, type B, 30 articles, type C, 21 articles, type D, 12 articles. So I thanks to our collaborator as a working group member of Japanese Society of Nephrology, and this data has submitted to the Clinical Experimental Nephrology 2026. So thank you. This is the Japanese cherry tree, all the way old, over 100 years. So PRG may be alive as this old cherry trees. I hope so. Thank you very much.